Jenny.
Thank you very much. I am concerned about your denominator data. You all seem very sure that you have got good denominator data, but you've taken a very small window of practice and multiplied it by the number of days in the year, from what I can see. And I'm not sure, I'm not convinced that that's accurate. Can you convince me?
Harriet, this is your job. This is your job. Now, I would make the point that, and Harriet will run through this, that great care was taken not to include day of the week bias or specialist unit bias, which is terribly important with a cross-sectional study. Harriet.
Yeah, so the first point to make is that sites were randomised to the 2 days of the week that they got. 2 days and everything. Exactly, and specialist centres were taken out of that randomisation and randomised separately. So, for example, neurosurgical units were treated separately and randomisation occurred within that group of sites. And so we hope that we had an even representation of different types of hospital across the different days of the week. We then didn't just multiply that up by the number of days in the year. We did try to take into account, for example, the number of bank holidays in that specific year. So we actually multiplied the number of weeks by 50.24, sort of 50.6 in the end, to try and take into account the days that would be more like weekend working. So
emergency work will be different, won't it? I mean, you may lift out neurosurgical, but more importantly, emergency patients must be treated in a different way when it comes to individual drugs, especially relaxants, as I'm interested in. So they will confound your data.
Yes, but we know which of those cases are emergency cases, I suppose. So you could produce separate denominators, I suppose, for the use of neuromuscular blocking agents in emergency cases compared to elective ones. If you wanted to go into that much kind of granular detail, we could do that. We have the data to be able to do that.
We have that in the supplementary.
I think this is probably something we ought to do and get back to you, Jenny. Yeah.
I think it's a very interesting area, and I'm not sure.
Yeah. I mean, on the subject of bank holidays, we chose periods that didn't include any bank holidays or public holidays or anything like that. But I think in relation to, we could do further analysis on all the data to look at emergency denominator data to see if it is different. Who knows? Yeah.
And we have actually looked at use of NMBAs according to site, according to emergency as well, according to NC pod category, and I believe all that is in the supplementary data of the Allergen survey paper, so you can have a look at that. And I think we tried to scale up the figures we received of those 2 days, taking into account information we might have not received, as Harriet has explained earlier. So we didn't only multiply by scaling 2 days to a week and then a week to a year, but also take into account the uninterpretable forms, the response rate by site, and the basically the numbers that we received. So we did the best we could, and this was done also in NAP6, and at the time it was discussed why it was felt preferable to do this over 2 days, over then a larger period of time, and we felt that it was a better representation of the information.
Okay. Another question.
Can I just comment?
Yeah.
As Susanna says, it was the same methodology as was used in NAP5. So J.D. Pandit led it in NAP5, and he presented a very robust statistical analysis, which was way above my head, as to why collecting data for 2 days was unlikely to be dramatically different from collecting it for 1 week or even in 2 weeks. I think it's related to the present distribution of data.
NAP5 wasn't perfect.
No, none of it's perfect. Can I be very clear? None of it's perfect.
Okay, more questions? Yes.
At least on paper, you seem to be linking hypotension with beta blockers and ACE inhibitors. Are you not just describing the function of the drugs rather than a link in the sphere of anaphylaxis?
Claire, do you want to
the
pick that
question.
one up? Could you repeat the question,
Sorry, I
please?
didn't quite hear that.
Sorry, the microphone isn't very loud.
So it seems just on paper there's a description of a link between the hypotension presentation and beta blockers and ACE inhibitors. Surely beta blockers and ACE inhibitors are antihypertensive agents. So is this just an exaggerated physiological response to the fact that the patients are on the medication and are unable to resist maybe another insult? Or is it actually an
So you are right.
anaphylactic?
Obviously, these drugs have exaggerated the anaphylactic response. And so you get very pronounced hypotension. I think you might hear from Tim later this afternoon that these patients on ACE inhibitors and beta blockers are also associated with higher grade events and maybe also related to more fatal events. So you hear about this. And you are right, of course you're right, because that's what you expect.
I think a further element, you're quite right, of the dangers of beta blockade in patients undergoing an anaphylactic reaction is that the beneficial beta agonist effect of adrenaline theoretically is largely blocked, depending on how well beta blocked the patient is. And as you'll hear this afternoon, this is where glucagon comes in. And glucagon is in our recommendations to give under those circumstances. Yeah. More questions? Yes, sir.
Hi, Sarang Purani from Kingston. So would you recommend, I don't know whether we'll talk about that later as well, but would you recommend giving antibiotics, especially now teicoplanin, awake before and 10 minutes before induction? And what are the implications? And second quick question is, would you always advise patients allergic to penicillin to get tested, to get it checked, and would the immunologist or allergist be happy for a burden of that work?
Okay, so
I think both these questions will be addressed this afternoon by Schwab.
yes, I was going to say
Yeah.
that it's one of the key messages I think from the antibiotics chapter. But the answer is yes.
You're ahead of us there.
Yes.
We don't still show Sunday
The answer
this
is yes.
afternoon.
Yes.
Ideally.
In terms of investigations, yes, you are right, capacity is a big issue, and I think we could use this to argue for investing more in allergy services so we are able to deal, because we are talking about 10% of the population, 20% of inpatients. It's a large number of patients, but based on the data we found and what you will see later on this afternoon, yes, there is a case for investigating all these patients, and some of that work is already being done by some of your colleagues. So, yes, is the answer. How is that going to be possible is another question.
Okay, Peter. Thanks, Laura.
From the non-anaesthetist point of view, what was the most surprising thing to you in this survey in terms of what you didn't expect anaesthetists to use, or you didn't expect them to use as much of, or less than what your preconceived ideas was?
I have to say chlorhexidine. Although based on the referrals I receive, where it is constantly underreported, it wasn't so much of a surprise, but it still is the most surprising finding, I think, because as we've established already here, it is ubiquitous, it is used by everyone, and nevertheless it was only reported to be used in, or patients to be exposed in 75% of cases. So I think that was the most striking one. All the other figures that we found, I don't think I had a particular opinion on, and from a non-anaesthetist perspective, I'm more used to seeing the referrals of the cases of anaphylaxis I see. So this was the most striking one, yes. And one that I think we need to raise awareness of, and now seeing as it is the third most common cause of perioperative anaphylaxis, as shown by NAP6.
Harriet, did you have any misconceptions about allergen exposures before the survey?
No, I don't think so. I think another interesting one that I highlighted was the choice of second-line antibiotics, particularly teicoplanin, which is used quite a lot, particularly in orthopedics and trauma, and the fact that this was driven in a significant proportion of cases by past history of allergy, which may be real, but we have a strong impression and evidence to show that vast majority of cases it's not. So I think that was the other striking finding, and to actually document that quite elegantly, I think was interesting and gives a little bit more strength to the debate of investigating these patients, as you were asking.
I think conversely, it was interesting to confirm some of our sort of vague preconceptions, such as the proportion or the numbers of exposures to intravenous paracetamol, for example. To put in, I've said for a long time it's almost impossible to have a general anaesthetic in the UK without receiving intravenous paracetamol, and that turns out to be pretty well the case. And antiemetics as well. All these things with good reason, no criticism there. But it's very, very interesting to put numbers to these. Mark.
I'll try and speak loudly. You've said quite a lot about preconceptions and delabelling. People coming along with a vague history of an allergy who don't actually have an allergy. Even in the last few days, I had a patient who'd come along with a vague history of penicillin allergy, was given ticoplanin therefore for prophylaxis, has a life-threatening anaphylactic reaction, and on subsequent testing was found not to have been allergic to the penicillin in the first place, but in the absence of any formal delabeling process, he now carries allergy information for both, and we're rapidly running out of antibiotics with which to treat him. How do we take this forward?
So first, starting with the last comment you made, is that he shouldn't really be carrying a label for both. And when he was investigated for his perioperative reaction, he should have been investigated for his penicillin allergy as well, which in fact drove the whole sequence of events. And so hopefully one of those labels would be removed. How do we tackle delabeling these patients is a very good question. It's been asked already, and the answer is we should be trying to see as many of these patients as possible, particularly the inpatients, I would think, which are sort of smaller population, starting with that, but certainly outpatients as well, because many of them will come to you. I agree that if there isn't a formal investigation, there is a risk that the patient is actually allergic, and you don't want to take that chance. There could be a case of trying to come up with algorithms, and a lot of in the allergist and immunologist community and anaesthetic community as well are coming up with work to try and establish some algorithms that will allow you to assess risk and stratify patients, so you could at least decide maybe not a penicillin but perhaps another beta-lactam like a cephalosporin. And I've heard a colleague saying that they tend to do that in patients with a label. They use a cephalosporin instead rather than using ticoplanin, for instance. So there are all those measures, and you will see quite a lot coming up. There's a lot of publications and a lot of work being planned in the near future to try and tackle this. Yes.
While we're on the subject, Shrev, this is your topic.
Yes.
Can we have your comment on that?
I'll just wait for the microphone.
I apologise to the other questioners. We just carry on.
This is clearly important, and this is one of the real highlights of this whole report. And I would say that it's not really a fault. Although we need more capacity in testing, etc., the fault lies in the labelling. Mm-hmm. And if you look at the NICE guidance, it talks about proper documentation, providing information for patients. When the patient presents with an allergic type reaction, or perhaps not an allergic reaction, and then is falsely labelled, that's where the problem lies. So we all need to get much better at writing down exactly what sort of reaction has the patient had. Was it a bit of nausea? Was it a little bit of diarrhea after taking penicillin? And then they've been falsely labelled. Which antibiotic was it? If we have a description of the drug, the exact drug, plus the reaction, then during anaesthesia, you would have been able to perhaps administer penicillin instead of ticoplanin. So the fault lies in the labelling. We've got to get better at labelling.
I think there's a pressing need for a symposium or a mini symposium in the allergy world on delabelling, and I think there's a strong directive coming out of NAP6 that this is sorely needed. to actually bottom this out and to look at ways forward. So that's a challenge to the allergy world.
But
It's time
to add a little bit to that, the problem is also that most of these labels are given in childhood. And by the time we see these patients, and most of you will have that experience, no one will have any recollection of what the allergy was or where the label came from. And although we know that in most of those patients, the label was probably incorrect in the first place, and some of them did have a correct label but outgrew their allergy in the space of time that they've had it and you've seen them, you still don't know who you've got in front of you. It may still be 2% of the actual numbers that come through, but you don't know if the one in front of you is the actual one. So delabeling is, I think, still the main action to take. And perhaps starting in kids with the viral infections that are treated with antibiotics, and then a rash comes up and the label of antibiotic, normally penicillin allergy, comes through. So that is, I think, another piece of work.
Yep. There's a need for a consensus approach to delabeling and how this is done and what's needed to do that. Yeah. One very quick question, please.
Can I just clarify about MHRA reporting? Because everyone that's mentioned it says it's appallingly done. Now, I refer every patient that has a reaction to a tertiary centre. Should I be producing a report at that point which includes 7, 8, 9 drugs? Or do we wait for the answer? And then does the tertiary centre then do the MHRA report? Or do I then put in a report when I get the written report back from the tertiary centre?
May I comment on that? It's an excellent question. Could we park that until, not least because it's lunchtime, could we park that until Neil Maguire's presentation later on? And he's the man to address that question. Are you up for that, Neil?
I'm just going to be going to hide in a small cupboard in the corner.
It's a rhetorical question. Okay, well, thank you very much for your attention. Thank you for the speakers for keeping so well to time. A round of applause for the speakers, please. And can we see you back, please, at 2:15 prompt? Thank you very much.